All right, good morning, everybody. Happy Valentine's Day. It looks like maybe a lot of the class is busy on Valentine's Day. It's kind of early, but whatever. That's cool. I hope everyone had a good weekend, ready to get back to it. I've got, well, you can't really see here. These are different, the pelvis bones of different lizards. And you can see they make an appropriate shape for today. So basically the same structure as in human pelvis bones. You have the pubic symphysis up front here, and then they come back together and bind with the equivalent of the sacrum kind of posteriorly here. But if you look at it at the right angle, it's an appropriate way to start our lecture for today, in which we'll wrap up the appendicular skeleton and move on to talk about joints a little bit. And that will kind of wrap up this section on bones for us, which works nicely because this ends the topics that'll be covered in your exam on Friday too. So your program for today was pretty no, I didn't give you any program for the weekend. So you're good to go here. Any questions before we jump into it today? All right, let's wrap up the appendicular skeleton. So we've got, we're going to start off with just a review of your ticket out from Friday. I've got a review activity for you as usual to get your brain thinking about the appendicular skeleton. We'll finish up talking about the lower limbs, specifically the ankles and the feet. I've got another review activity for you built into lecture today, and then some reminders and a ticket out at the end of class. Pretty standard format for us. On Friday, on your way out the door, I asked you to name the bones with which a coxal bone directly articulates. And overall, the class had the right idea here, but I want to make sure we've got some good understanding. Coxal bone, of course, articulates not first and foremost, but with the femur. Of course, this happens at the two hip joints here and here. We have the acetabulum of the coxal bone articulates with the head of the femur, that really nice ball and socket joint. We'll learn about those different joint structures in class today. So most of you got that. Now remember that the coxal bone also articulates with the sacrum here and here. We have these relatively inflexible joints. So posteriorly, each coxal bone is articulating with one side of the sacrum. And then finally, don't forget that the coxal bones also articulate with each other anteriorly at the pubic symphysis. And this is the one that not as many people put down as the others. I was glad to say that nobody said it articulated with the lumbar vertebrae or the patella. A few of you said that it articulated with the coccyx. Remember, the coccyx is this bone down here. It articulates only with the sacrum, and so there's no articulation between the coccyx and either coxal bone. So make sure you've got that. What I did last time is I asked you that same question on your ticket out for today that I asked you on Friday. Now that we've reviewed it, that last week everybody got the right answer on your way out the door on Friday. So I'll ask you the same question again today on the way out, just to make sure everyone's got that. Sound good? Cool. Quick review for you. Okay, on a piece of paper, I'd like you to identify structures A through F. I don't have a timer for this one, but just go ahead and set your pen down when you're done. Do your best as you can from memory. As always, then if you need to look things up, that's fine. But try to pull it out of your brain to start. And this is exactly like a question you can expect to see on your exam, something similar to this. I give you the diagram, tell me what this stuff is. We'll also get into these bones in more detail in lab this week as well. See a couple people still writing. I'll give you another 30 seconds or so. All right, so your answers should, yeah, most people are got this down. Actually, let's see, a couple of people still writing. Let me give you a second to finish up your last ones there. Your answer should look like this. Whoops. A is the carpals, so you can see it's a bracket here. Just kind of these general bones right here are your carpals. B is the metacarpal. These are the bones in the palm of your hand. C is the phalanges. Now remember, we have 3 phalanges on each digit except for the thumb, which has 2. So the thumb has a proximal and a distal phalanx. The other digits, 2, 3, 4, and 5, have a proximal, a middle, and a distal phalanx. So it's that 2, 3, 3, 3, 3 pattern we talked about in class. D is the lunate and E is the scaphoid bone. Remember, those are the 2 carpal bones I'd like you to be able to identify, specifically because these 2 bones articulate with which bone of the interbrachium? The radius, good. And then we have the pollex. So all of this here is our thumb, or pollex, more specifically. Also, remember that the pollex is digit 1. We have our digits numbered 1 through 5. And so I want to put up this view. Here's an anterior view of the right hand. In other words, it's like this, right? And you can see 1, 2, 3, 4, 5 to identify our digits. Remember also, you've got a couple sesamoid bones right here in the joint in your thumb. These are bones that are kind of integrated into that tendon there. Now, notice that, how do I want to do this? As you can see here, this is an anterior view of the right hand, and if we flip it around, you can see how the anterior view of the right hand looks different from the posterior view. And specifically, so what we have here is the anterior view of a right hand. What you have here is the posterior view of a right hand, right? So this is just a hand, the same hand flipped over. And it's a little tricky, but there's a few identifying features that you can use to tell whether it's an anterior or the posterior view of a hand. One of them is the position of the distal end of the ulna. Note that the lateral process, the styloid process of your ulna is a little bit posterior. So if you look at your hand, your wrist, you see this bump coming up right here. Notice that that's a more prominent bump from the posterior view than the anterior view, for sure. And you can see that process here a little bit better defined from the posterior view than from the anterior. You can see it's kind of back there. You can also see the metacarpals here extend further towards the palm from the posterior view than they do from the anterior view. And that's just because of the shape of that joint between those metacarpals and the carpals. You can tell that way. There's some other differences as well. These bones actually, some of these bones project outwards, like towards you. It's a little bit hard to see here in 2 dimensions, but when we get to lab, you'll see specifically the scaphoid bone and the palmate bone have a 3-dimensional shape that makes them more easily identifiable. And we'll see that in lab. So I want you to be able to tell whether you're looking at the back of a hand or the front of a hand based on a few characteristics. Ethan.
It's kind of like a semantics question, but I want to make sure. So if we were to have this like this on the exam, would you take off points at all for labeling F thumb instead of pollex?
I would be clear about it because thumb is not incorrect. And so, you know, for example, if I ask you to name what part of your leg is from the knee to the ankle, and you said leg or shank or cruce, all of those would be correct. So if I want a specific answer, I will be specific. So for example, if I said, what is the name of this digit, I don't know, other than the thumb or something like that, you say pollex, yeah. But yeah, I'm fine with using thumb and pollex interchangeable unless I specify, yeah. Go ahead, Dan.
So will you require us to know like I don't know, front and back and left front and back?
Yep. That's why I wanted to show this, because I should show you a diagram on the exam and say, okay, is this the anterior or posterior view of a left or right hand? And you'd have to work through and figure that out based on the features of the bones I just talked about and also what side the thumb is on.
Would the sesamoid be another one to look at to determine, or is that kind of not?
Oh, yeah, thanks. Yeah, if you can see the sesamoid bones, that means that it's an anterior view because those bones are here. If you're looking at it from the posterior, you won't see those. Yeah, that's a good call. So you can check out those sesamoid bones too. Good. The foot's a little bit easier to tell the top from the bottom because of the way it's structured and the heel and everything, but the hand can be a little bit tricky. Sound good? All right, boom. Let's do this. Let's continue talking about the pelvic girdle. We left off here on Friday. Just a quick review here. Orient you. Actually, our review question got to this. I want to remind you that the acetabulum, again, here is where the hip joint is with the femur. And then, let's see, I mentioned this, just a couple other reminders. The coxal bone is formed by the fusion of 3 bones during development. You have the ilium superiorly, the ischium posteriorly and inferiorly, so in the back, in the bottom, and then the pubis, which is on the bottom and the front, so that's inferior and anterior. Remember, ischial tuberosity, this big feature right here, is the attachment point for your hamstring muscles. Also, this is where you bear most of your weight while you're sitting, right? So just a couple reminders there. We went through all of that on Friday. And I showed you, did I show you this X-ray on Friday of the bones developing? I don't remember if we got to here. Okay, so you can see in development that they are 3 separate bones, but they fuse. They're basically indistinguishable. There's no lines in adult bones. And remember that the 3 of them come together right here at the bottom of the acetabulum. So right there in the center of the bone. You have a question? No. I thought I saw a hand. Question, Casey. Yeah.
Is the space in between, like, is that just connective tissue while it's developing?
Yeah, it's specifically cartilage. So you've got all of this is cartilaginous, and that cartilage over time ossifies and the bone forms there and then eventually just fuses till there's no cartilage. So it's the exact same idea as like an epiphyseal plate in your long bones, and the same idea as like your skull, the way your skull fuses, which I haven't gotten to yet, but you know when a baby's born they have like that soft spot? That's the exact same idea. Those bones of the skull aren't completely fused yet, and you've got space in between, and that's just protected by cartilage. Great question. And that's because babies are super flexible. During development, it's really important that they can bend and contort for a lot of different reasons. One of them specifically is childbirth. And so the bones of the head is a great example where if those bones were rigid and formed during childbirth, that would be a lot more problematic for both mom and baby during birth. Good. So let's look at this. Let's continue looking at the hip bone. We talked about that. I covered the ilium, ischium. I think we left off. Did we compare? We did compare male and female. Did we do this? I'm sorry, I don't remember exactly where we left off. Okay, so we left off here. Again, just a reminder, looking at the difference between a generalized male and a generalized female pelvis. I want to just re-emphasize that there is a continuum here. And so what you see here is kind of the ends of the continuum, some obvious examples. But remember, there's lots of pelvis structures that are kind of in between in there. It's not completely dichotomous one or the other. In most cases, an anatomist can find it, if they find a skeleton or something like that, you can identify it as male and female based on these structures, but it's not 100%. There are definitely lots of intermediates there as well, especially depending on how old that skeleton is. Let's move on then and talk about the lower leg. Did I?
Yeah,
Oh man, we were left off here, didn't we?
Yes.
Okay, I'm really sorry about that. I was thinking that we still had to cover. Okay, I'm just going to do a quick reminder of the shank or the leg. We have the tibia and the fibula, of course. We have the malleoli on either side there. On one side formed the fibula, one side formed by the tibia. And remember, this is a site that is often broken. I don't think I showed this x-ray, did I? When we talk about breaking your ankle, it's often, in fact, this malleolus that breaks. Remember, those 2 structures on the tibia and fibula form this kind of clamp that allows your foot to move really nicely in one plane, up and down like this. But it's much more challenging to move back and forth. And in fact, when it does move back and forth, those are different joints that are moving, not this joint where your talus articulates with the fibula and the tibula. And so when we talk about breaking an ankle, you're actually breaking the distal end of your fibula or your tibula, depending. And that brings us to the foot. So the foot has a structure homologous to the hand, which means that it has basically the same generalized structures. So it has 7 tarsals, like your hand has 7 carpals. Then it has 5 metatarsals, and then 14 phalanges. So the same general structure as the hand. The foot is really important, as you might imagine, because it supports our body weight. So it's important for when we're stationary, but also the foot acts as a lever to help us move when we're walking or running. And we have this very unique structure of bones here, but also I want to emphasize that there's a lot of soft tissue. There's a lot of ligaments in there that keep your foot very pliable, because it needs to be able to move and keep you balanced and moving across uneven surfaces. And so you're constantly making adjustments. So there's a lot of joints in here that can very subtly shift your balance so that you can maintain that balance under all kinds of different conditions. I want to talk about two of the bones of the two tarsal bones specifically, just like I gave you two carpal bones. The first is the talus here. The talus is the most superior bone of the tarsal bones. Notice here we have, this is the medial view, right? So this is looking at the side of a right foot. So imagine somebody standing like this now. My left foot's out of the way. You're looking at my right foot from the side. We have the talus here. Notice it's got this smooth surface here where it articulates with the tibia and fibula in that kind of pivot fashion. We'll look at those joints in more detail in a minute. And this part of the talus is called the trochlea. Do you remember you had a trochlea on another bone as well? Yes. What's that? Yep, you have a trochlea on the distal end of your humerus at your elbow, right? That's that rounded, smooth surface that where the olecranon of the ulna forms that kind of cup to form your elbow joint. Same idea here. You have this rounded, smooth surface on the talus that's called the trochlea. I also want you to know, I should have highlighted, oh no, I did highlight these in the slide. I also want you to know the calcaneus, which is this really big bone back here. This is the bone in the heel of your foot. And those are the two I really want you to pay attention to. There's 5 others here that form, that fill out the rest of the tarsals, but I want you to just focus on those 2. The calcaneus, and you'll see this from a different view in a minute, is notable just because of its size, but this is where the majority of the weight of your body goes when you're standing, although it is distributed amongst here, and also it shifts as you're walking and moving around as well. So the 2 tarsal bones I want you to know are the talus and the calcaneus. Go ahead, Ethan.
The whole bone you would associate as your heel is the calcaneus, but specifically the bottom is the calcaneum tuberosity.
Yeah, so the calcaneum tuberosity here is the attachment point for a number of important tendons. And so basically all of this is your heel. Now what we commonly call the heel is made up of this bone, but also like your Achilles tendon and other soft tissue back there. So I would say that think of this as the bone that's in your heel, but don't think of this as just your heel itself, because there's other stuff in the heel as well. Let's see, is that what I want to say on this slide? Yep, that sounds good. That's all I'm going to say about the tarsals. Just focus on those 2 major ones. One other point too, sorry, I should have mentioned this, is the talus is the only tarsal that articulates with the tibia and the fibula. This is the only articulation point between your foot and your leg. We can then move on and talk about the phalanges. So we have the same formula as in your hand. They're numbered 1 through 5, with your big toe being number 1. And each of those toes has the proximal, middle, and distal phalanx, except for the big toe, which here is called the hallux. So we have the pollex and the hallux are the thumb and the big toe. Now I didn't say much about the metatarsals here. They're similar to structure in the hand, and you can see them in between the tarsals and the phalanges, of course. Yes, question, Hannah.
Can you just go back for a second about the trochlea? Yeah.
Yep. Yep, Ethan.
This is a bit more of a vertebrate anatomy question. But if we were to compare the foot of a human to a foot of a great ape, would we see kind of the same structure but just more dexterous?
Yes, you would.
Hands. What's the big difference there?
So if you're comparing this to like a gorilla or an orangutan or something like that, what you'll see is a couple things. You'll see that the hallux is more, it's not as parallel to the other the other phalanges as our big toe is. Like our hand, the thumb kind of sticks off to the side. It's similar in other great apes as well. Ours is pretty parallel. Our feet are basically like super evolved for walking and running, whereas those of the other great apes are used for walking, but in a different way. They're also used for brachiating, climbing trees, and they also have more dexterity in them as well for different things. So yeah, so they would essentially their feet would look more like their hands than our feet look like our hands. That's a really good question. We can look at that. You got to take vertebrate anatomy. Zoology 331, if anyone's interested in this. I'm teaching it again. Actually, I won't teach it again for a while. Fall, what year is this year? 22, holy jeez. 20, so I'll teach it again fall of 2023 probably, if anyone's still around. So basically we take all of this, but look at everything from fish to frogs to great apes to antelope to cats, etc. I say actually we don't talk about cats that much. I just said that, but now that I think about it, we don't really get into those guys too much because we get to dissect them in here. All right, so here we go, phalanges of the foot. So not going to spend too much time on this. There is a lot of cool physiology with the foot in terms of the arches of the foot and how the foot acts as the shock absorber and then a spring when you're running. Just not going to cover that in this class simply for time. I want to just talk about the general structure. But just know that there's lots of cool, important things going on with the foot. It's not just like a peg leg where it hits the ground every time you walk, but it's a very dynamic structure that helps us locomote. And one of the many features that makes us such good runners is our feet. I mentioned earlier in the course, of course, our ability to sweat. Also, world champion sweaters. Dan, you had a question?
Yeah, so we would have to mainly know like that the hallux is just the big toe. And...
Yep. Okay. Yep, absolutely. You need to know this term for sure, hallux. Hallux and pollux. All right, I want to do a quick review activity with everyone. You're going to do like a think, pair, share activity. Well, it's really green, just like super green all this. It's like the Hulk up here. All right, so turn to someone sitting next to you. And what I want you to do is you're going to create a Venn diagram that describes the characteristics of the feet and the hands. And specifically here, I should say the skeletal structures of the feet. So you're going to draw something that looks like this. On one side, you guys know I love Venn diagrams. On one side, you have hands. On the other side, you have feet. So I got you started a little bit here. The hands articulate with the carpals. The feet articulate with the tarsals. Both hands and feet have sesamoid bones. So you can draw different categories. Go ahead, take a couple minutes, work with a partner. You can make one diagram between the two of you. That's fine. If you want to group in groups of 3 even, that's fine too, but no more than 3. If you want to work on your own, that's fine too. And just a quick review, thinking about the similarities and differences between the bones of your hands and your feet.
Yeah, what's dexterity? Work for it. Like, if you get like dexterous, like moving one individual,
Yeah, I'm talking about like when it can do like this.
Oh, hey.
Yeah, you can definitely move it more slightly.
yeah.
Yeah, I think it's definitely really good.
Something that should go in the middle is the 3-3-3-3.
Oh,
Right there. So the feet forming up one articulation with the bones, whereas the hands have 2 articulations. Yeah. Well, I think that would say just with the radius and the scapula are associated with the radius, whereas with the foot, only the talus. So it's like 1 bone, 2 bones.
and then you have Talus.
There we go. All right, when you're ready, send a representative from your group down here and just go ahead and fill in one thing that you came up with in one of those categories, but don't repeat. So if someone else already did one, then you're tasked with finding a new one. Should be some chocolate. Oh, here you go. If I just do this. There we go. Can we just put this over here? Yeah, just leave it there again. Yeah, just one person from each group. Come on down. Just one of your.
No, it's fine. I can't.
Good. Thanks, everyone. So the idea here is just so you all have a study guide. We're missing a few groups here, but I'm not going to worry about it too much. Your hands have more dexterity, more mobility. So you articulate with the radius. That's good. So we don't have what bones the feet articulate, the bones of the leg. What are the two bones of the leg? Tibia, fibula, good. Smaller and more nimble. So the bones of your pinky toe, for example. Your little tiny pinky toe has 3 little bones in it, which is kind of cool to think about. Nimble, I'm not sure exactly what you mean there. Just be careful because you don't quite have the dexterity with your toes, of course, as you do with your hands. Your feet are, of course, supporting the body weight good. You've got this 2-3-3-3-3 formula. Again, the bones of the pollex and the hallux. The big, your thumb and your big toe have 2 phalanges, and the rest of them have 3 each. Go ahead.
Is the phalanges on like the pinky toe considered short bones?
Those are still considered long bones, even though they're short. Remember, long bones are defined not by their size, but just how wide they are relative to how long.
Those phalanges are taller than
Yeah, so all of your phalanges are still technically considered long bones, even though they don't fit the general, like, I don't know what you think of the stereotype of a long bone. Those are just 'cause they don't you guys. Yeah, and specifically the pinky toe, those bones are really tiny.
Yeah.
Good. Anything that anyone would want to add to this list? There's lots more to add, but I just wanted to get you thinking about it more than anything. Okay, we could also add in both of these that, remember, we have the metacarpals and the metatarsals are similar structures in the hands and the feet, in that they're the bones that join the carpals in the hands to the phalanges and the tarsals in the feet to the phalanges. All right, let me put this back down. I want to talk really briefly here about a couple disorders of the appendicular skeleton. 2 notable congenital disorders, meaning that they can happen early in development. Well, I guess hip dysplasia, well, it could be congenital. It could be caused by congenital factors. This is when the head of the femur slips out of the acetabulum. So you see an example here, and you can see that based on this radiograph, you can see that this bone, the ilium, and right here, the ischium is not, no, that's actually the pubis here. See how they're not fused? So this is a kid early in development. And notice how this femur is, on this side, the femur is just out of socket right there. It's not even articulating with that. So there's that big gap in there. That's hip dysplasia. That's the head of the femur coming out of that acetabulum. Of course, it can happen later in life as well. We also have something called clubfoot. This is when your legs are structured such that the soles of the feet are kind of turned in medially. And this can be corrected early in development with like corrective braces or possibly with surgery as well. Of course, when you're a baby, this isn't really going to do too much to hinder you. But as you develop and as you begin to walk and things like that, it can obviously impair that. Go ahead, Shir.
So in the situation of hip dysplasia,
Mhm.
what's the condition of that ligament that is connecting the femur to the metatarsal.
Yeah, so the fovea capitis could be stretched or broken in that case. Yep, and we talked about that a little bit in class. I'm not sure if they have to reconnect it when they fix the hip or not. That's an open question. Yeah, I need to check out that. Good. And one other point I want to just make here is that the ratio of your body structures change throughout life. And so specifically when we think about the appendicular skeleton, your limbs grow a lot faster relative to the rest of your body. So when you're a baby, your head is giant compared to the rest of your body. Your torsos are always really big, and your appendages are smaller. And throughout development, that ratio changes so that by the time you're fully grown, your head is much relatively smaller, and your limbs are much longer compared to your torso. There's more to the development than that, but I just wanted to show you how that works generally and think about how the appendicular skeleton is very underdeveloped when you're born. And throughout life, those bones grow very rapidly compared to other bones in the body. Your textbook, this is a diagram from the textbook. It gets into a little more detail as well. And that's all I want to talk about the appendicular skeleton. Before we talk about joints, what questions do you have? All right, so joints are simply the articulations of your bones. They're where those bones come together and in some cases move and in some cases don't. You can see here a view of the knee. Just as a little bit of refresher, is this a medial view or a lateral view? Are you looking from the side coming in or from kind of inside going that way?
Medial.
Medial, yep. How are you noticing? Yeah, so you've got the tibia here and the fibula is lateral. Remember, the fibula is always going to be lateral. So this is a medial view. You've got the head of the femur and you've got your patella right there. All right, so joints are, as I said, they're locations at which rigid elements of the skeleton meet. And we're going to classify joints a couple different ways. The first is their functional classification, which is describing them by how much movement is permitted. And there's three categories by which we functionally describe these joints. The first is called Esin Arthroses, or synarthritic joints. These are joints that don't move. The bones are together and there's not movement between them. So for example, the bones of your skull are completely fused together. There's dense connective tissue binding them together and there's no movement there. So essentially the bones of your cranium act as like a single bone, even though it's composed of many smaller bones. So these kinds of joints are more common in the axial skeleton. So for example, well, I'll just leave it there. We'll get to more examples coming up. We then, okay, so if we're classifying these functionally, we have three categories. One describes joints that don't move at all. What are the other two categories, do you think? Joints that move a little bit, joints that move a lot. Exactly. So Amphiarthroses or amphiarthritic joints are joints that are slightly movable. So we've got a little bit of motion in there, but not a whole lot. So that would be something like your pubic symphysis. Those bones come together. There can be a little bit of give, but it's not like a full-on articulation. There's not a lot of motion going there. And finally, we have what we commonly think of as joints, diarthroses or diarthritic joints. These guys are freely movable and movable. There's a new word for you. Freely movable. And they're all your synovial joints are diarthritic. And we'll talk about what a synovial joint is in a second, but these are like your stereotypical joints, your elbow, your wrist, the joints between your metacarpals and your phalanges, your knee, your hip joint, all of those joints where you've got a lot of motion are your diarthritic joints. Yeah, Ethan.
So what takes an amphiarthrosis joint to a diarthrosis? joint?
The amount of movement that's possible,
Is there
basically.
like a certain like measurable level of like
That's
what's that level?
So is there like a quantified threshold?
Yeah.
I don't think so. I think it's more of just like, this one moves a lot, this one doesn't. Like there's no like, if it can move 37 degrees, it's one or the other. It's not really like that.
Do you know if there are any that kind of ride that line?
I'd have to think about it. Let me come back to that as we give some examples. Yeah. Yeah, there certainly are some what I would consider kind of gray areas. Let me hold that thought. Let me come back to that. Oh, I just thought of an example. We'll get to it. Good. I knew I could come up with one. Okay, so those are the three functional classifications of joints. I want to make it clear here that we're going to classify joints another way in a second. So we need to make sure we're clear on what a functional classification is, what they do. Again, we have three kinds of joints that are immovable, Synarthroses, kind of movable, Amphiarthroses, and very movable, Diarthroses. And now we're going to talk about how we classify them structurally. And by structural classification, I mean by like what's in them. What are the material that's binding the bones together? And is there a joint cavity? So these are different categorizations, although you'll notice some overlap here. For example, all of your synovial joints are going to be diarthritic. They're going to be very movable. So the first kind of structural classification of a joint is fibrous. So these are bones that are connected by dense fibrous connective tissue. And so these joints tend to be immovable, synarthritic, or slightly movable, amphiarthritic. So again, this is like the sutures between the bones of your cranium are like this. We also have cartilaginous joints. So these are bones connected by cartilage, and they're not highly movable, but there's a little bit of give there. And these joints can be synarthritic or amphiarthritic. So for example, hyaline cartilage connects your ribs to your sternum, right? That would be a cartilaginous joint, and it would be considered amphiarthritic because there is a little bit of movement, but not a whole lot. The pubic symphysis falls under this category. It's cartilaginous. Remember, there's fiber cartilage between the two anterior portions of your two coxal bones, and that there is some slight movement there. So those are your cartilaginous joints. And then the final kind of joint on which we'll spend the most time, because it's the most diverse and interesting, are your synovial joints. And these are joints that have a cavity between the bones, like a pocket, that is filled with something called synovial fluid. And these are the joints that are highly movable. So the takeaway here is that we can think of synovial and diarthritic joints as being not synonymous, but if we drew the Venn diagram of all the joints in the body, most of the ones that are synovial would be diarthritic, and most of the diarthritic would be synovial. So there's a lot of overlap there, right? Yes?
I don't know if you said, I can't remember if you said it or not, but in bones that are forming and diffuse slowly, would those be
Cartilaginous? Yes, so when those bones are, yeah, that's a good point. So when those bones are coming together, so for example, in the coxal bone, early in development, we saw those three bones fusing together. When they're bound by cartilage before they fuse entirely, those are cartilaginous joints, and they would be considered either synarthritic or amphiarthritic, probably synarthritic there. Yep. And then later as they fuse, they become completely fused, boom, there's no joint there anymore. Another great example is your long bones. Those epiphyseal plates, those growth plates in your long bones, those are cartilaginous joints while you're developing, because technically there's two parts of the bone there that are brought together by cartilage, but once you stop growing, once you reach maturity, those joints fuse and that joint essentially goes away. Let's see, this is just enough time to talk about. So let's talk about some of the movement that we can create with these joints. There's three general kinds of movement. And this is where I'd love to combine this class with like a dance class, and we could do all of these movements and learn about anatomy and dance at the same time. I don't know anything about dance, so we're not going to do that. However, I can tell you the three basic types of movement. First is gliding. Those are essentially when bones are just sliding along next to each other. The bones of your carpal bones as well as your tarsal bones are great examples of that. When you move your wrist, all of those bones are kind of gliding along each other in a very kind of complicated way in the case of both your carpals and your tarsals. We then have angular movement, which is when the angle between two bones changes. It's just what it sounds like. And so a great example is bending at the knee, bending at the elbow, right? We have just like you can think of putting a protractor here, and you can change the angle between the antebrachium, between the ulna and the radius, and the humerus. That's angular movement. And then we have rotation. This is when bones are moving around their long axis. They're turning, basically. So I can rotate my humerus. I can rotate my femur, right? There's lots of examples of that. Those are the three primary kinds of movement that are created by those joints. Now I want to get in and just give you a little more detail about some of those different joint types. And that's all we're going to cover about joints. Not too much, but I do want you to know some of the anatomy of them. And also just they're so functionally important. We rely on our joints so much for everything we do that we want to have some idea of the structure of them. I'm just going to skip ahead for 1 second and just take a look at what I have lined up. Oh yeah, there's some examples here. Okay. So I want to give you examples of each of these now. I want to emphasize that I don't need you to know everything on these slides. All I want you to take away is that these are examples of the different kinds of joints. So what I want you to know is the different kinds of joints and be able to give an example in the body. So for example, we have fibrous joints, right? That is where bones are connected by these dense connective tissues. I don't need you to write down all of this. Of course, you're welcome to, but you don't need to know all these details. The takeaway message is that there's very little space between the bones, and between the bones there's this fibrous connective tissue, and there's no movement here. And so these are synarthritic joints. And in fact, as you develop, the bones just basically fuse together and form something called synostoses, which is when that bone is just grows completely together in this interlocking pattern. So we've got sutures are an example of fibrous joints. So if I was taking notes here, I would put fibrous joints. One kind is a suture. Sutures bound together by fibrous connective tissue, no movement. That's the takeaway.
What was the second thing you said?
Sutures are a form of fibrous joint, and they're bound together by dense fibrous connective tissue. So that's one kind of fibrous joint. Another kind is something called a syndesmosis. This is when ligaments are binding bones together. So for example, the distal articulation of the fibula and the tibia there. And there can be some movement here. So these can be synarthritic or amphiarthritic, depending on how much movement is created. And so another example is the distal articulation of the radius and the ulna. We have a joint here. It's bound together by these fibers, but there's a little bit of movement. And we kind of have, remember, we have this interosseous membrane also holding all of these together. And so whether those fibers are really long or short will determine how much movement there is. And then let's see here. I've got one more kind of fibrous joint. So just to refresh your memory, actually, let me put this up on the board. This will make it a little bit easier to make sure we're getting the big ideas here. We've got three kinds of fibrous joints. Suture. We've got a syndesmosis, and then we have a syndesmosis, and then we have something called Gomphosis. You see that here, there's only one place in the body where we have this. Well, there's a bunch of them, but there's only one place where this happens, and that is in your teeth. This is a unique joint to your teeth that doesn't occur anywhere else in the body, and it's this what's called a peg and socket joint, and we have these ligaments that very tightly bind the tooth to the bone surrounding it. And so it's a kind of fibrous joint. There's ideally no movement going on there, hopefully, except of course during development when you can get a loose tooth and all that, which seems weird. Now, I can't get over how weird it would be to have your teeth just kind of falling out. Like my kids are losing their teeth, and it's just like such a bizarre thing to imagine, like your tooth just getting loose and popping out of your mouth. It would freak me out. Anyway, Gomphosis is the last kind of fibrous joint, and that is only found in the teeth in the body. I'm going to stop there. I'll pick this up and cover cartilaginous joints and synovial joints in more detail on Wednesday, and we'll move on from there. So this marks the end of the material that we will cover on your exam. And I want to remind you that your exam will be Friday. Class will not meet in here on Friday. Instead, you'll have that time to work on your exam through material that we covered today. Be a combination of multiple choice, drawing, labeling, short answer questions. You should be familiar with these. I want to make sure, also, I put in the, did I announce this to the class yet? I don't remember. Did I announce this on Friday, the review session? Yeah, I did. I can't remember what I did anymore. So every Tuesday from 6 to 8 p.m. via Zoom, Chase is going to hold a review session. She wanted me to make sure I got the word out in advance of tomorrow. I put the link to this is in your class program for Wednesday. And also it is, it's in Blackboard as well. So you can log into that. I definitely recommend checking that out. Your class program for Wednesday is simply some tips on reviewing for your exam. There's no new material to cover. It just gives you some information about the review session, your exam, and then some advice that I have about how to structure your studying for your exam. Otherwise, just a reminder that my open hours today are short. It's only 1 hour from 1 to 2, but I'll be there. And then I've got a couple questions for you and a chance to upload your Venn diagram from class today. Once you wrap that up, we're good to go, and I will be happy to answer any questions.